Hello everyone, this is a brief tutorial on the parasternal short axis view of the heart. Begin by using the phased array probe with its low frequency and small footprint that fits nicely between the ribs. Remember to choose a cardiac preset. Before we proceed, it should be noted that the radiology convention for the parasternal long has the indicator on screen left. Cardiologists place the indicator on screen right, which means the heart will have a reversed orientation. We will be using the radiology convention since this matches the orientation of our probes for almost all other applications. For the short axis, the indicator will remain on screen left, thus the probe indicator remains directed towards patient right. In the cardiology orientation, the probe indicator will be rotated towards the patient left, but the screen indicator is now moved to screen right, so the resulting image is actually identical. The anatomy of the parasternal short view includes the RV, the LV, the septum, the papillary muscles, and the pericardium, which surrounds everything, but is not usually visible unless there's an effusion. Near field is patient anterior, and this is what a typical image will look like. To obtain the parasternal short view, you're going to start with a good quality parasternal long view. Heel the probe to make the septum horizontal. Rotate the probe 90 degrees counterclockwise, and then sweep, or if necessary, slide the probe a tiny amount to obtain the papillary level. Let's review some of these steps in more detail. Heeling the probe will make the septum more horizontal. If the septum remains too vertical, consider the sliding of the probe a little more cephalad to another rib space and trying to get another parasternal long image, and then try heeling again. If the septum is not vertical when you rotate the probe, the parasternal short view will have an oblong shape instead of the nice circular appearance that we are looking for. Once the septum is in vertical, make sure to center the mid-LV on the screen to match where you're going to rotate. Rotate slowly counterclockwise until the circular shape of the parasternal short comes into view. If you lose your image, stop rotating and try sliding a tiny amount to get your view back. Here you can see the probe rotating into counterclockwise in an exaggerated motion. Note the operator would normally have the hand resting on the chest wall. For a well-controlled rotation, hold the probe near its business end and stabilize your hand on the chest wall. Use your thumb and index finger to gently turn the grip. Once you have your round parasternal short view, sweep to find the papillary muscles at the level of the LV. If you are tilted too much towards the head, you may see the aortic level instead. Caudal to this is the mitral valve level, and beyond this is the papillary level. This is the best area to eyeball gross LV function. As you sweep to find the papillary muscles, the image may become too distorted. It can be worth trying a small slide in the plane of the long axis of the heart instead. This move will be limited by the lung, but can generate a superior image in some patients. Here we see the operator sweep to find the papillary level and then try a little sliding. Note that these are normally very small motions. Here you can see how the three major levels of the parasternal short view differ from each other. The mitral valve will have a fish mouth appearance, the aortic valve will have its distinct tricuspid look, and will be surrounded by several different looking chambers. Let's move on to interpreting the parasternal short image. Three things you need to look for: adequate contraction, concentric squeeze, and ventricular dilation. To assess contraction, look for 30% fractional shortening, just like you do with the parasternal short view. Eyeballing this particular video, you can see that it shows a normal squeeze of over 30%. This heart has reduced function with a fractional shortening that is clearly less than 30%. Here's a heart with extremely poor contraction and a squeeze that is less than 15%. Note that we are at the level of the mitral valve here. If you see an elevated ejection fraction where the heart is squeezing so hard the two walls are almost touching, we call this the kissing ventricles. Here's a heart trying to pump out every last drop of fluid, and you will see this in severe hypovolemia or hemorrhagic shock. Just like the parasternal long view, you can appreciate left ventricular dilation when the wall-to-wall distance is greater than 5 centimeters in the average adult. With growing pressure in the right heart, the right ventricle enlarges and the septum begins to flatten, creating a D shape in the left ventricle. The D shape will initially be visible during diastole, but with increasing right ventricular pressure, it can continue to exist during systole. Note that with chronic right ventricular dilation, the free wall of the right ventricle will usually be greater than 5 millimeters in thickness, which is best appreciated on a subxiphoid view. You can see the left ventricle has a D shape in both systole and diastole in this image, indicating high right-sided pressures. The right ventricular wall thickness is also greater than 5 millimeters, so this is likely a chronic finding. Remember that generating a good parasternal short view begins with a good parasternal long view. Rotate 90 degrees counterclockwise, sweep or slide to the papillary level. Look for at least 30% fractional shortening, concentric squeeze, and no right ventricular or left ventricular dilation. This marks the end of the tutorial on the parasternal short view. Thank you.